Well, hello then, everyone. Welcome. My name is Konstantin Obolensky from DynaMesh. As I said, welcome to today's session, the role of material in pelvic floor surgery. Just as a brief introduction on how today's session is going to run, we're going to have two presentations later by two great experts, Dr. Jordi Sabadell and Professor Bernd Klosterhalfen. After which we will have an extended Q&A session to go through any points or issues that might arise during these presentations. Feel free to leave all your questions either in the chat or use the raise hand function. We will then go through it one by one and make sure no question gets left behind at the end of the session. Please be aware, though, that this session today is being recorded, and therefore also your questions will be recorded and be used for further educational and promotional purposes. So without holding it up too much longer, I will now hand over to my dear colleague Axel Dievernich, a soon-to-be PhD in theoretical medicine and also an absolute expert on biological materials. So Axel, for the time being, over to you, and I'll see everyone at the end of the webinar again and hope you enjoy today's session.
Thank you, Konstantin, for the kind introduction. I would like to welcome all the participants and especially our two speakers to today's webinar with the topic, the role of material in pelvic floor surgery, which will be structured in two parts or two presentations. The first presentation will be given by Professor Bernd Klosterhalfen, who is well known in the field of mesh explants and biomaterials due to his extensive knowledge. He has been assessing mesh explants now for over 30 years. He's the head of the Institute of Pathology at the University Hospital in Düren. And since 2001, he's the head of the German Center of Excellence for Biomaterial and Implant Pathology. He will give us a glimpse, or he will tell us more about the foreign body reaction in terms of different biomaterials. And he will also show us some really interesting pictures. Our second speaker, which we're really happy to have, is Dr. Jordi Sabadell. He's a member of the Urogynecology and Pelvic Floor Unit at the Department of Gynecology at the University of Vall d'Hebron, I hope I pronounced that correctly, from Barcelona, Spain. He's conducted a lot of research over the last 10 years, focusing on slings, but also other topics in the gynecological field. And recently he published a really interesting, independently of FEG, a really interesting multi-center RCT, where he compared polypropylene and Pvdf transobtural slings. And we are really excited that he will present us his results. And I think afterwards, or we will see how the results or the findings from the pathology really great correlate with his clinical findings. So again, we are really happy that we have both speakers. And I would like to ask Professor Klosterhalfen to start with this presentation.
Yeah, thank you, Axel, for the kind introduction. Good afternoon, ladies and gentlemen. And again, it's a pleasure to be a part of this webinar. And today, we have a short talk about the biocompatibility of mesh. And today we have the focus on the materials we use in these meshes. In particular, I will have a direct comparison of polypropylene and Pvdf. And before I do that, I have to give you some disclosures. And just starting my presentation, I just want to summarize what we have done in the last 25 or 30 years. And meanwhile, we have investigated more than 10,000 explants of hernia and pelvic floor meshes. And if you just want to summarize the main findings we had in this data pool, is that you can say that serious complications, just like shrinkage or chronic pain, correlate basically with the extent of the foreign body reaction or the chronic inflammatory response to these meshes and to the fibrosis. Important is the so-called bridging fibrosis. This is a special kind of fibrosis. So bridging fibrosis means that the whole mesh is encapsulated in scar tissue. This is exactly what we don't want to have. And we know that fibrosis and bridging fibrosis of flat textile structures mainly depend on two factors. One, probably you know, it's the surface area, so the area which is in contact to the host tissues, and this parameter mainly depends on the pore size. And I think you all have heard the terms like large porous mesh or small porous mesh. But the second factor are the polymers, and the polymers even have an influence on the fibrotic reaction. And just as a reminder for you, just a small summarizing of the importance of the pore size. So what you can see here is the result in this draft of 1,000 polypropylene meshes, which have been used in hernia repair. And basically, we distinguish today a couple of classes of meshes, but the most important classes are class 1 meshes, so-called class 1 meshes with large pores, and class 2 meshes with small pores. And you can see here on this draft, the large porous meshes are indicated by these blue circles, and the small porous meshes are indicated by the red circles here. And on the bottom, you have the formation of connective tissue. And on the left side, we have the inflammatory response. And the first, what you can see that it's very different in each group. This reflects the genetical background of each patient. But if you look at the means, you can see here in this cloud and in this cloud that the connective tissue formation and the inflammatory response is significantly reduced in the large porous group. So what you can say, yes, large pore or small pores, this characteristic of textile meshes, this really is important for the biocompatibility of the mesh and the outcome of mesh. And this is a very old picture from Aachen. And this is exactly what we want to have. You see it on the left side. This is an explant of a large porous mesh. And even after long-term implantation, you can see a very, very low fibrotic reaction. You even can see the mesh fibers through the mesh, and this is exactly what we want to have. And if you look at all of my data pools for hernia meshes and pelvic floor meshes, you can say that if you compare class 1 and class 2 meshes, that the main complications like shrinkage, chronic pain, fistula formation, and so on, and infection, that the complication rates in class 2 meshes are significantly reduced compared to the class 2 meshes, the small porous meshes. So I think this as a small introduction. And now coming to the polymers, this is the second factor which influences the fibrosis of the meshes, and therefore the choice of the polymer is pretty important. And now just for the beginning, a small trip onto the surface of a mesh. And what you can see here, this is the mesh fiber, and now we will just go to the surface of the mesh fiber here. This is the polypropylene fiber. And what happens if you put the mesh into the body, within seconds or minutes, the whole mesh is covered by proteins you have in the body, in particular albumins or fibrinogens, and these proteins are degraded by the polymer. Degraded proteins, however, are a pretty strong immunologic stimulus for macrophages which are coming in contact to these degraded proteins. And finally, macrophages cover the surface of the polymer with these degraded proteins, and these macrophages, independent on the degradation of the proteins, are activated and start to liberate a huge cocktail of mediators, inflammatory mediators, growth factors, chemoattractants. And the most important cells which it's attracted by these activated macrophages are the fibroblasts, and these fibroblasts start to form connective tissue, in particular collagen fibers. And finally, if you have a cross-section through the mesh after long-term implantation, you can see here the polypropylene or the polymer fiber, the macrophages, and independent on the activation of these macrophages, you see scar tissue around the mesh. And if you compare, for instance, Pvdf and polypropylene, and if you have the same mesh structure, the same diameters of the fibers, and the same pore sizes, you will find that the foreign body granuloma and the fibrotic reaction in case of the polypropylene is twice as high than in Pvdf. And this is pretty important for the outcome of the mesh, because if you have the same pore size and you have an increased fibrotic tissue reaction in the polypropylene, it's more likely that the pores are filled with scar tissue, and this is exactly what we don't want to have, because this is what we call bridging fibrosis, and this is what I told you before is the factor which correlates with the serious complications like shrinkage and bridging. But there's another aspect which is pretty important. Excuse me, my computer. Okay, now it's a question of degradation, and this point came up in the litigations in the United States and in Australia. And basically degradation influences the fibrotic reaction around the mesh too, and it's basically not a new story. This is a graph or a picture of a pretty old study from 1995, and at that time basically it was clear that polymers may degrade into the body, and here you have a direct comparison between polypropylene fibers and Pvdf, and the outcome here is the tensile strength over long-term implantation. You see here 1 to 7 years, and what you regularly can find that the tensile strength of polypropylene significantly decreases over time. The material becomes stiff, and in contrast to that, PVTS remains pretty stable and flexible. So basically, this is nothing very new, but during the course of the litigations, there was upcoming another topic, the surface degradation of these materials. And basically, there are a lot of publications in the literature saying, yes, polypropylene degrades. Basically, polypropylene shows signs of degradation, and you will find cracks and small particles at the surface. And there's a very small group to say, no, this is not true. Basically, what you see in these pictures of these materials are simply rest of biological material, and basically the fibers or these meshes were not cleaned sufficiently. But I have to say, I'm a strong believer in polypropylene oxidation because of a couple of reasons that basically you only have to trust your eyes. The first reason is if there's no oxidation of polypropylene, you have to ask you why most manufacturers add antioxidants to their raw materials, question marks. This is simply a question. And basically, if you look at biological material surrounding mesh fibers. This is an old picture from Calvé from Nizza. Here you see the fiber, and this fiber is surrounded by biological materials. Here you see proteins and basically cells. Here, these are erythrocytes, and basically this is connective tissue or extracellular matrix. So biological material is looking like that, but what we see is something completely else. And so just look and trust your eyes. Basically, this is a polypropylene fiber of a mesh before implantation, so a pre-style mesh. And what you can find on all these meshes or mesh fibers are so-called extrusion lines, which are remnants of the production process of these fibers. And if you see these extrusion lines, you can be sure that you are on the top of the surface of the fiber. This is an example of a polypropylene mesh. This is an example of a Pvdf mesh. You see the extrusion lines here. So you are on the top here, higher magnification. These are the extrusion lines again. But what we see are pictures like that. This is completely something other than what I showed you before from Calvé. Here you see these particles, which are only some microns big, and you see these cracks. And what you can see here, this is the surface of this fiber, and here you see these extrusion lines, so you can be sure that you are on the top of the fiber. And these are not materials on top of the fiber. You see, this is a degradation of the surface itself. So the question, another example, excuse me, this is a very fine example, because there's one mesh on the market which is made from Pvdf and polypropylene fibers at the same time, and this mesh was implanted in mice, I believe, for 4 weeks. And here you can see the Pvdf fiber. Here you can see the polypropylene fiber. And on top, you see again this extrusion lines. And here in the higher magnification, even after 4 weeks, you can see the first cracks in the polypropylene, whereas the Pvdf is completely normal. The question is, of course, whether this flaking or degradation of this polypropylene has any biological effect, and I will tell you as a pathologist, yes. This is a light microscopic picture of a polypropylene fiber. This is the fiber. This is the scar tissue surrounding the fiber. And what you can see here are these blue marks on the top of the polypropylene fiber. This is the degraded material. We have other examples. This is another polypropylene mesh which was surface modified by titanium, and you see the same degradation of the surface in this mesh. So the modification has no influence on the polypropylene degradation. And what you can see in most of these explants showing a strong degradation of the polypropylene. This is again an enhanced inflammatory response, like here, these blue dots here, these are inflammatory cells. And here you see these particles, and this is a higher magnification. These are the macrophages. Here you see the particles again with a size of microns. And if macrophages phagocytize very small particles, they are again activated and again start to liberate a huge cocktail of medias, in particular pro-inflammatory cytokines like interleukins, TNF, as well as growth factors, forming again fibrotic tissue. And so it may happen that even after long-term implantation, after weeks or months or years, you again have an activation of the chronic inflammatory response against the mesh, and again you have an increased fibrotic reaction, exactly that what we want to have. So if you compare Pvdf with polypropylene, basically you can say Pvdf has a lot of advantages. It had only one disadvantage, a little bit more expensive. But if you look at all aspects of biocompatibility, there are, in particular, if you look at the foreign body reaction and the long-term stability I think Pvdf is a superior material. So summarizing, you have to know as a user of these meshes, basically polypropylene degrades pretty early, a couple of weeks or months after long-term implantation, and degraded polypropylene is basically stiff, it's no longer flexible, and the tensile strength is reduced. But I think the most important disadvantage is that, in particular, these small particles you can observe in our electron microscopy pictures. If they are phagocytized by the macrophages, they again enhance the foreign body reaction or chronic inflammatory response and the fibrosis. In contrast, Pvdf has a pretty good long-term stability. We don't see this form of degradation, and the material remains flexible and smooth even over years after implantation. And so the material should be basically, in particular in the pelvic floor repair, superior to other materials, in particular polypropylene. Thank you.
Thank you very much, Professor Klosterhalfen. This was really interesting. Are there any urgent questions right now? I will just wait a short time. But so far, it's quiet. Otherwise, we'll just do the discussion, because I think there are a lot of points that we can discuss afterwards. If we now see the clinical results of Dr. Jordi Sabadell, then I think afterwards we can really greatly correlate the theory of the pathology with those clinical results. So, Dr. Sabadell, please go ahead.
Okay, thank you. Thank you very much to DynaMesh and Dr. Klosterhalfen to let me let me share with you our results from this study. Okay, so I'm going to present you our results from a randomized controlled trial comparing polypropylene or Pvdf transobturator slings for stress urinary incontinence in females. As you know, there are lots of surgical techniques for stress incontinence, but since the 90s, mitral slings have become the first-line surgical treatment for many urogynecological and urological teams for stress urinary incontinence because of high cure and improvement rates, along with a good safety profile. However, complications do exist, and some of them could be related to the material, such as vaginal extrusions or extrusions into the bladder, pain, de novo urinary incontinence, and sometimes we need to release and to make a section of that slings. So, as you know, the vast majority of the commercial kits of many brands are based on polypropylene. However, Pvdf is also available in Europe for the use in urogynecology. And it has some potential benefits over polypropylene, such as a lower elongation and lower deformation capacities and improved biocompatibility and less foreign body reaction than polypropylene. However, in the literature, there are scarce, it's sparse to the date. In fact, in the last publication by the ICS in the book of incontinence, they only mention a descriptive study by our group that we have published on 2016. In this study, we observe good cure rates with both sling, with both materials, but polypropylene began to decrease their effectiveness during time, in contrast to the Pvdf that remains stable. So based in those results, we designed the present study. The present study was a multi-center randomized control trial that in which have participated 11 centers of Spain. We performed a block randomization process with a stratified by center, and the allocation was considered in a web centralized. The eligibility was pure stress urinary incontinence or stress predominant mixed urinary incontinence, and the main outcome was the cure and improvement rate based on a composite objective and subjective criteria. We use also the validate questionnaires of SAMBIC, ICQ, short form, and the patient global impression of improvement. We estimate that we need 282 patients to find a 10% difference in the effectiveness at 1 year. We perform both an intention to treat and a per protocol analysis, and the protocol of this trial was published on Clinical Trials. So this is our results. We randomized 285 patients at the end of the recruitation. And finally, 134 and 137 patients per arm were analyzed. The baseline characteristics and severity of incontinence before the surgery was similar in both groups. And this was the results about effectiveness. We found a very high effectiveness with both materials, and those differences was not statistically significant. Pvdf with a 95% of effectiveness and PP with a 91. In the per protocol analysis, the results was almost the same. And based on the questionnaires, all the questionnaires improved significantly after the surgery, and the vast majority of patients were very much improved or a little bit better than before surgery. Failures in the polypropylene group was because of persistent stress incontinence in 3 patients, because mixed urinary incontinence in 4 patients, another 4 patients with severe de novo urge incontinence, and 1 voiding dysfunction. Whilst in the Pvdf, there were 6 failures, 2 because persistent stress incontinence, and 4 cases because mixed incontinence. Regarding the complications, we don't find differences regarding complications in the intraoperative, early postoperative, or late postoperative periods overall. However, we found that de novo urge incontinence was more frequent significantly in the PP group. We found 16% of de novo urge incontinence of new onset or worsening previous symptoms. We also found another complications that were more prevalent or were more incident in the PP group, like pain or dyspareunia or the need for a slim division. However, those differences was not statistically significant. However, we have to say that this study was designed to compare effectiveness of both materials and therefore is underpowered to find differences in events that has low numbers. In conclusion, what we have found is that PP and Pvdf show similar high effectiveness when they are used in transobturated subforeal slings. They have a similar overall complication rate. However, Pvdf seems to show less mesh-related complications such as de novo urge urinary incontinence or less pain events. with Pvdf. Therefore, Pvdf seems that will be a good alternative to polypropylene for the use in mitral slings. This is all our presentation, and we thank you to be here. If you have any questions, I will be glad to try to answer you. Thank you very much.
Thank you very much for your presentation, Dr. Sabadell. Yeah, we have actually now a couple of questions. The first one is to Professor Klosterhalfen from Ameya Padmara. I hope I pronounced that correctly. So the question is, does that mean that the mesh incorporating Pvdf will offer better pelvic support and chances of extrusion will be less?
So, excuse me. Yes, basically, as we define an excellent incorporation of the mesh is that what I try to show you, that the fibrotic tissue reaction around the mesh is basically at a minimum. You don't need no excessive fibrotic response. You need a little bit so that the mesh is included in the host tissue, and so that the mesh still remains flexible and is able to keep its function. And basically, so the pelvic support should be better. Basically, you have to prove, of course, this theory by clinical studies. But yes, I believe that if you compare the integration of polypropylene and Pvdf, that the integration of Pvdf meshes is superior and should have a better pelvic support, yes.
Yeah, so thank you for the answer. Then there's, I think this question goes more into the direction of Dr. Sabadell. It's when using Pvdf sutures to anchor the meshes, knotting ability compared to polyester was difficult. What is, or it goes in, to both speakers. What is the expert's recommendation on sutures used for anchoring of meshes in pelvic floor repair?
Well, I have no experience on sutures with those different materials. We use both absorbable and not absorbable with PP sutures for pelvic meshes in colposacral plexus, but we have no experience with Pvdf sutures. We have only the experience with slings and the meshes itself. And with the meshes, there is no difference. And the fact that it's quite good to work with Pvdf slings. You have a good sense while you are working with it, but with the slings. But I have no experience with knots, with sutures.
Okay. Then there's a question regarding degradation. Are the degradation processes of PP dependent to the location where the implant is placed? Hernia versus pelvic floor, respectively, abdominal wall repair versus transvaginal repair in pelvic floor surgery?
So basically, the process of degradation, what we observe in the electron microscopy is pretty the same, even if you look at meshes used for hernia repair on the abdominal wall or on the pelvic floor repair. The reaction to the material is very, very similar. Of course, we have differences in some mechanical aspects of the abdomen and the pelvic area, but basically the processes, what we observed in all our explants, are very, very similar in both places, and the degradation is similar too. So basically, I would say it's identical. There are no significant differences.
Okay, thank you. So there's a question from García Molina. Do you have any experience with Pvdf in contact with the bowel? So I guess that's more to Dr. Sabadell.
Well, thank you. Yes, directly no, because the more field for the general surgeons. I'm a gynecologist, so I'm not used to treat abdominal wall hernias, but by their input, they could use, as far as I know, Pvdf meshes to leave them inside the abdominal cavity in contact with the bowel. I have not a direct experience, but when talking with my colleagues of general surgery, I think that they can use Pvdf inside the abdominal cavity, but not with polypropylene if it is not special prepared for it.
Yeah, thank you. This may be also, well, of course, I'm not a user, but this is actually also one of my fields. So I'm doing the clinical evaluation for the IPOM mesh. That's the intraperitoneal mesh that we have, and I can assure you that, of course, there can be complications, but we have really good results. And so there, of course, there's also contact with the bowel, and there's nothing to worry about it.
Maybe Axel, if I may add to that. So yes. Basically, I think if you look at the results in the literature, you have to say that polypropylene within the abdominal cavity is now a no-go, because we know that you have a lot of serious complications like adhesions and fistula formation over time. And if there's any material which you can put in the abdominal wall, it's only Pvdf or at maximum ePTFE. But I think polypropylene, this shows the literature, this is basically a no-go today.
Okay, there's a follow-up question on this one. In your opinion, if you have to pick up only one, what is the main reason to use Pvdf slings versus polypropylene? So maybe to both of you. I think we answered that from the biocompatibility, I guess, but still, yeah.
I think one of the major points, excuse me, Jordi. I think that one of the major points, if you look at the explants which are sent to me, to my institute, and meanwhile I got every day I become explants from the pelvic floor. If you look at the material and if you take it in your hand, if polypropylene is explanted, this material is really stiff, hard, shows folds, and I believe the main argument, in my opinion, is really the long-term stability of that material, because basically your intention is to have a long-term repair, and therefore the material must be adapted to long periods of implantation. And I'm not sure whether polypropylene is an adequate material for that because of this degradation.
Okay, then there's a question regarding the RCT of Dr. Sabadell. It's which PP product did you use in the study? Were both slings equally elastic?
Well, we used 3-4 different brands. Each center used the brand that they use in their daily practice. So there are 3 or 4 different brands, maybe with different elasticity and slight different physical characteristics. However, those are the brands with each center have the best results. So as a pragmatical RCT, we decide to use each center use the brand that they use in their daily practice. So there are different brands, yes.
Mm-hmm. Yes. Again, another question to Dr. Sabadell. Do you think the visual properties of Pvdf can explain the minor incidence of adverse events in your study? So I think it's superficial properties.
Yeah.
Or
well, obviously I cannot be sure, but it could be. This is the rationale to hypothesize that Pvdf could be superior to polypropylene regarding complications, and those complications that we have observed are in line with the theory, that Professor Klosterhalfen or before have observed in animal studies, and it could be the answer of one of the reasons why we found those differences or those differences in numbers. But it's true that we have to be cautious from the C of the clinical, because there are small numbers, only 282 patients, and we need more follow-up or more patients to be sure of that. Results. But yes, that property of Pvdf could be a reason for lower complications. Yes.
Yeah, I think especially like some of your complications, or the complications that you recorded, they correlate well with the findings of the pathology in terms of a greater foreign body reaction, then of course a greater induced inflammatory stimulus, which might also come in waves because of maybe this degradation. So it could be that there are, because it's an ongoing foreign body reaction, it could be that there are, like, I don't know, after a year or something, that there could be another spike in terms of an inflammatory spike. And so I thought, from my perspective, I thought it was really interesting that there was also in your previous retrospective study, I think it was really interesting that you had these differences in de novo urginary incontinence, and also in the RCT that there was this difference in long-term pain. So this, I think this really correlates well with the findings, or also what Professor Klosterhalfen was saying. And also I just, sorry, yeah.
Yes, thank you. I'd like to add that the complications that we have observed in that RCT are more or less in the same line that in the first retrospective cohort study that we have published before. Are also more complications like urinary incontinence, pain, and also obstructive events in the PP group in the first observational studies. So they are in the line of this theory. I cannot be sure of that, of course, at this point, but it fits with that rationale.
Yeah, I'm just, it's my personal interest, and I think, of course, also the company's interest. I'm really curious on more long-term results of those patients, because I thought in this retrospective study that you did prior, I thought it was really interesting that the cure and improvement rate stayed about the same for Pvdf, but it steadily decreased in the polypropylene group. And so, scientifically, I'm really interested in the long-term results of this patient cohort. Yeah.
Maybe I can add, if you look at the data pool, what's interesting, if you see the mean time intervals of implantation, basically most of these meshes are explanted after 2 or 3 years. So this is very interesting, whether this is a point where you have where you can see the main differences between these two meshes.
Yeah, that's a good point. That's actually also something I noticed in your study, Dr. Sabadell, your prior retrospective study, because like you had 7 sling divisions in the polypropylene group there. I mean, of course, this was retrospective and you had a 1:4 ratio you picked. So you had way more meshes in the polypropylene group, but there were 6 cases of severe UUI and urinary urge incontinence, and you had 1 case of voiding dysfunction, and the mean average, or the median for these complications and the sling divisions was 17.1 months. So this is like over 1 year in the follow-up period. So we will see how this pans out, and if this how the RCT, what the results of this will show.
I hope to have the results of the RCT in the long time, in the next few years.
Yeah. There's so much coming in on different channels. There's also something, please discuss the impact of Pvdf versus PP on post-operative sexual function of patients after sacral Cortopaxy using mesh. Okay.
I have not that information because this study was not with our colposacropexy, and we have not performed that study with just under my totally subjective point of view. We have this perennial sexual dysfunction after colposacropexy. It's not very frequent. And we also see some case with polypropylene and also with Pvdf, but I have no information about numbers with that.
Okay, then there's a question about degradation. It's in clinical practice, after more than 1,000 procedures, I've never seen one disruption of a mid-urethral sling. A PP sling, of course. So how relevant is the reduction of the tensile strength? This is asked by Esvin Maya.
Yeah, that's a good question. So I actually don't know what is the critical level of the reduction of the tensile strength, and what we know from all the experiments that the tensile strength is reduced to the half after 5, 6, 7 years of implantation. That is exactly what we know. And maybe the tensile strength is still strong enough to take care for the surrounding tissues, but I'm not sure whether the tensile strength is really the decisive parameter if you look at degradation. So what I'm concerned about is that the mesh really becomes stiff. This is what I wanted, or what I told you before. If you take these explants into your hands between the fingers, you see that the mesh is really becoming hard, stiff, and is really not flexible anymore. And I think this is much more important for the function of the implant and the surrounding tissues.
Yeah, and I also think that maybe this tensile strength reduction, this is also, we have those two things that are working against each other. On the one hand, we have this, of course, stiffness and fibrosis that might be enhanced, and that's like really working against this also tensile strength reduction. So I like rupture, and it's also in terms of degradation, I think you showed it. It's more on the surface of the fibers. So it's maybe more of a stimulus that's provided for the surrounding inflammatory cells.
Yeah, and there's another point. Basically, if you look at the mechanical data of these meshes, so most of the polypropylene slings are made of small porous textile structures. Basically, if you look at the mechanical stability of these meshes, if you look at the rupture rates and tensile strength rate, the material is mechanically mostly much too strong. So it exceeds the mechanical stability levels of the host tissues, sometimes with factors of 10 or 20 or 50 times stronger than the materials around. Even though if you have 50% loss of the tensile strength of that material, it's still enough to support the tissues around the mesh.
Yeah, I think it's more like the histology looks gruesome with all those fibrosis and stiffness. So at least this is what I also saw in histology and explants, and yeah. I think this is also pretty much what we just discussed. It was the question, what is the clinical translation of clinical consequences of degradation? So maybe, yeah. There's one question which I kind of by Adam Evans, which I kind of ditched so far because I'm not sure. It's can Pvdf be sterilized with irradiation without comprising the mechanical properties? I think it can, but I'm not sure. This is not my. I might come back to this. Please, you could send me an email about this, and I could really ask there our experts in the company that really have knowledge of this. So yeah. Then there's okay. Then there's another question, but I think I will ask it. How do you compare Pvdf with Gore-Tex mesh in clinical applications for abdominal sacral Cortopaxy? Do you have any idea, Dr. Sabadell?
No, we don't have a Gore-Tex for Cortopaxy, so it's not.
And yeah, that's what I thought. That's also why I kind of shifted that question back. Okay. So, are there some more questions?
There's still a raised hand from Dr. Burkhard Abendstein. I'm not sure if it's the question we had earlier. Dr. Abendstein, if you want to, you can unmute your mic.
It has already been answered. Thank you very much.
Okay, very good.
Thank you for asking the question. But there's a new hand now, and it's from Gerald Jan Schütt. I will give him the rights. So I think we can, you're still muted. Yeah. Oh, it's withdrawn.
Yeah? Oh, sorry.
I try again.
I am very sorry. I was moving my mouse in the wrong direction.
Okay.
Sorry.
No problem. Okay. All right. So really, like what I think what we have all taken from this really also interesting presentations is thus far, I mean, it seems like, oh, there's a new question which just came up to FEG. Which DynaMesh will DynaMesh be expanding its commercial availability to more countries? I am making maybe a kind of bold statement. I think we will, but right now it's, or you go ahead, Konstantin.
Yeah, I think I'll pop in. Theoretically, yes, it is a question of which country we're talking about. Maybe we're already in the process. I'm not sure. But yeah, theoretically, right now, as everyone probably knows, we have the MDR coming in Europe. So we're working very strongly on preparing and getting ourselves through that, and we will. 100%. That's a given, but at the same time, obviously, yeah, there is no limit to any markets that we don't want to enter.
Yeah. So yeah, so now any more questions? If you have any questions, go ahead. I'll just wait a couple of seconds now. But it doesn't look like it. So yeah, so I think to kind of conclude and to bring it together, I think right now it really looks interesting. Also from scientific point of view, it really looks like all this theory and all the results that Professor Klosterhalfen has collected and the theories that he has created with others, that this correlates well with the clinical results thus far. And so, I mean, we of course we are convinced of our products, and we know that they are performing great, but it's it will also show, or it has been shown in studies, but it will also show in your study, I think. Yeah, there's again a question, Konstantin. DynaMesh hernia products are approved in the US. Oh,
I just answered the question in the chat because I thought that's really interesting for everyone.
Yeah. So from my side, it was a pleasure doing this talk. No, not this talk. To being the host and to also talk with the two speakers, who I'm really, or I think also the company, we are really happy that you had your presentations, and it was really interesting. We learned a lot. And so, yeah, from my side, thank you very much.
It was my pleasure.
Yeah. Then also from my side, thank you very much, Axel, for the great job hosting. Thank you, Dr. Sabadell. Thank you, Professor Klosterhalfen, for these very interesting talks. I really enjoyed it. It was great to see the connection between theory and praxis here really coming into play. Thank you everyone for participating today, especially the ones that so actively participated in our Q&A and discussion. As always, as I said at the start, this webinar has been recorded, so it will be made available to everyone for further review. If there are any further questions that we haven't answered yet or are popping up for you now after the webinar, please feel free to just email them to us at webinar@dyna-mesh.com. We will then make sure to forward it to Dr. Sabadell or Professor Klosterhalfen, or answer it internally here, depending on the kind of question, so that we all go home happy and satisfied, hopefully. So yeah, once again, thank you very much for our presenters. Thank you very much for hosting, Axel, and thank you very much for everyone participating today. Everyone, take care, stay healthy, and have a nice evening.
Thank you.
Goodbye.
Bye.
Bye.